To all who are new here, welcome to Releve Sports Medicine's virtual journal club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our upcoming schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review the questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. A PDF of the PowerPoint for today's talk is available for download from the dashboard, and that you will find in the handout section. There will also be a link for resources from Dr. Hall that's available in the chat box at the bottom of the welcome message. The recording will be available for review from our website tomorrow. Dr. Emily Hall is currently Assistant Professor and the Clinical Education Coordinator at the University of South Florida. As a graduate of the University of Connecticut, Dr. Hall earned her bachelor's in athletic training prior to moving on to Indiana University, where she received her master's in athletic training and PhD in human performance. Dr. Hall's area of research examines chronic ankle instability, specifically on the rehabilitation strategies for the prevention of recurrent ankle sprains, where she has published and presented both nationally and internationally. I'm proud to present tonight Dr. Hall. And I'm going to go ahead and make her the presenter. So you should see a button pop up.
Okay. Do y'all see my slides? Can you see that okay?
Let's see, not yet. And there is a play button that says show screen.
Okay.
Under
let
sharing.
me try to do that again. It says it's showing screen 2.
Okay, let me try. I'm going to try to change it back to here, and then okay. I should have gotten that button pop up again.
I did. And I'm sharing the screen with it. Oh, 2020 is still with us. Okay. Let me try and try another. How about now? Nothing still?
Not currently.
Okay. How about now? Nothing.
Okay, how about one other option is we can I'll go ahead and pull up your slide on my slide deck here. I'll save it to a
Let me try one thing on my end.
okay. If not, I can click through the buttons on a jump drive.
Yeah, everything looks good on my end. Microphone. Yeah, I'm sorry.
That's okay.
Don't know why it's not working.
Mhm. Okay, can you see that?
Yes.
Okay, well, I will go ahead and advance when you tell me to.
Sorry, thank you about that. Sorry about that. Okay, thank you everyone for this opportunity, especially at Releve Sports Medicine. Really excited to be able to share something I'm very passionate about, which is chronic ankle instability, and we'll just go ahead and get started for the sake of time, especially. All right, so just to start off, I have no conflicts of interest. I will be sharing a lot of information that was shared at the International Ankle Symposium that was back in October 2019, so a little over a year ago now. Just really wanted to take note that all of the information I learned from that event, and as well as the research synthesis that went into this presentation, is all based on my views and my own synthesis. So it's not at all a reflection of the International Ankle Consortium. Okay, next. Sorry. The purpose of this presentation is just to share the emerging evidence from that 8th Annual International Ankle Symposium, specifically related to the conservative management following an ankle sprain. And with the objectives of this presentation, we'll be able to identify any impact that ankle sprains have on public health, as well as be able to choose then the appropriate treatment to really mitigate those long-term problems that come from that initial ankle sprain. Of course, we'll be able to talk about the specific clinical and patient-reported outcome measures to really then be able to improve patient care, specifically in those with following an ankle sprain. And then bringing that all together, we'll be able to apply an effective rehabilitation protocol into your own clinical practice. So before I really move into the presentation, I would like to do the poll at this time. So there's 2 questions to this poll. The first is, have you or someone you know ever experienced an ankle sprain? Go ahead and click yes or no. Okay, that should be enough time if you want to close that and show the results. Okay, yes, everyone has encountered someone who or themselves have sprained their ankle before. Great. And then the next question is, since everyone has or knows someone who has sprained their ankle, the next question is, has anyone or have you or that someone you knew sprained their ankle multiple times? So did they, after that initial ankle sprain, did they go ahead and sprain their ankle again? Yes, no, not applicable would be if you hit no, but no one at this point did that. So, all right, yes, no, yes or no. Okay, that should be enough time. Nothing that really requires you to think that much. Okay, great. So as you can see, I think there's about, 75 people in this webinar. Everyone has either encountered someone with an ankle sprain and then subsequent ankle sprains down the line. So great. We'll go on to the next slide. Okay, so here's just some hard evidence that solidifies what we kind of just realized with just this small sample, is that, almost 630,000 ankle sprains occur annually. That was a study back in 2010, but if you think about it, looking at your own population or looking at your own, either yourself or that someone you knew, how many of them really went on to seek medical care? As you can see, even not only seeking medical care or proper diagnosis, they are also not receiving the proper rehabilitation that following that ankle sprain. So even still with that, low reporting number, low compliance within rehabilitation or treatment, there's still a $6.2 billion in annual costs. And I'm sure even, that was a study done back in 2007. I'm sure now that number has just risen. So we can assume that this is a significant healthcare burden. So why, I'm sure either kind of a deep reflection within yourself, or I'm sure you've heard this within your, while growing up to be the clinician that you are. I'm sure you've heard in the past, oh, it's just an ankle sprain. You can, walk it off or, just tape it up and go. But really kind of going down the line, we are realizing that this is becoming a significant healthcare burden following that ankle sprain. Next slide. So again, this is catching up with the research that we are figuring out that there's more problems that are developing from just an ankle sprain. So in fact, that those who sustain an ankle sprain are, as you can see, 5 times more likely they're going to sprain it again. And these recurrent sprains, the perceived instability that leads to it, can lead to chronic ankle instability. These are prolonged symptoms of, sensory motor deficits, which having those deficits will lead to a decrease in physical activity. This decrease in physical activity will decrease their overall quality of life. Also then that brings into a increased fear of re-injury. And over time, the repetitive micro trauma that's happening with these recurrent sprains or these deficits associated with it can lead to this post-traumatic ankle osteoarthritis or cartilage damage associated with that. So next slide. This with the next slide of chronic ankle instability, a lot of things you may think like, oh, it's just for older individuals or post-traumatic ankle osteoarthritis. I don't have to worry about that. That's for old people. But really, we are finding out that even adolescents, 20% of adolescents in, of a sample of 2,000 high school aged students, they already had chronic ankle instability. So if they are already getting chronic ankle instability at this point in time at the high school setting, you know, just think if they're not doing anything to fix that, they're going to be at an increased risk of post-traumatic ankle osteoarthritis, you know, much earlier in life. You know, maybe not necessarily come college, especially if you're a college athletic trainer, but you know, they're going to be showing up in the clinic later on in life because they are developing this ankle osteoarthritis. And just some more information about chronic ankle instability. This prospective study that was done by our colleagues over in Dublin on patients with a first-time ankle sprain, they sought treatment in a hospital emergency department, and then they found that 40% of those of that sample ended up developing chronic ankle instability within their first year. So, you know, if you think about it, I think the re-injury rate of ACL tears is about 30%. Please don't quote me on that, but that's just a brief literature search that I did. So, you know, we are obviously much more, you know, much more into these ACL, you know, trying to do our very best to prevent these ACL re-tears, you know, in the clinic, athletic training room, etc. But we're not really doing that good of a job with these ankle sprains that are happening because, you know, they are developing these high re-injury rate, these prolonged symptoms following their initial ankle sprain. So as you can see from this chart or this figure with chronic ankle instability, the important determination is that those with chronic ankle instability, they must be outside of the 12 months from that initial ankle sprain. Anything that happens within the 12 months is just part of the healing process, you know, but it's from that initial ankle sprain. Whereas if they ended up spraining their ankle at like month 6, you know, that wouldn't necessarily be known as chronic ankle instability, but it's probably putting them on the track of having these recurrent ankle sprains. So we don't classify someone with chronic ankle instability until after month 12 of their initial ankle sprain. They develop these recurrent sprains. The persistent symptoms include pain, swelling, decreased range of motion, weakness, and decrease of function. As well as these frequent episodes of their ankle giving way. So like how that is kind of described is where they feel like they have uncontrollable stability within their ankle. So if you think of, you know, I'm sure some of you probably have this. So if you are thinking about, you know, walking down the street and you're like, oh my God, my ankle just turned. That is that frequent episode of your ankle giving way. You don't necessarily sprain it, or you don't necessarily develop the pain associated with a common sprain, but you kind of just like turn or slightly roll your ankle, but you're able to kind of keep going. Sometimes you may take a little bit to recover from that, and that's, you know, that's kind of what that giving way sensation is. One more important thing to note too is that this condition is so complex that not everyone will have the all of these symptoms from the get-go. Someone may just, you know, their symptom is just perceived instability, where they feel like their ankle is so weak, or they feel like their ankle is going to give way every time they step off a curb or go down the stairs. So, you know, they may not have the full pain, swelling, range of motion deficits that may be associated with it. But we'll talk about that more in the next slide. Let me go ahead. All right, so again, I told you this condition was very complex, which is why we have this this whole wonderful representation by Dr. Hurl and Dr. Corbett of this updated model of chronic ankle instability. So before it was, you know, just comparing functional stability and mechanical instability, but now they took over all the primary components, which include primary tissue injury, pathomechanical impairments, sensory perceptual impairments, motor behavioral impairments, personal factors, environmental factors, component interactions, as well as the spectrum of clinical outcomes. So, you know, specifically looking at the on the right side here, the environmental factors, these are all very important things that we really want to be able to capture, because that will affect someone's, you know, we'll be able to identify any barriers to the treatment. If we're able to identify any barriers to the treatment, then that may help with compliance down the road. On the flip side, we have the patient's personal factors. So again, possible barriers that may be if they're, you know, at a much higher peak of strength and conditioning, they're going to be able to recover a little bit more quickly than someone with a lower level of strength and conditioning. Their skeletal alignments, things that we can't really control about them at that point in time of injury. Someone's psychological profile too can also have an impact on their recovery as well. So again, these kind of follow the models, the ICF models, to be able to capture the factors that may influence injury. And if we take a look at the big box here in the center with all these little circles, so these are a list of all the impairments that someone with chronic ankle instability could have. Again, like I said before, they may not have it. Not every patient with chronic ankle instability will have it, but you know, if we don't measure it, we won't know if they have any of these deficits. If we can identify the deficits, then it would be much more focused, centered rehabilitation plan, much more efficient than with your time as well as money. So yeah, we'll talk a little bit about it later on, but before I move into the next one, go ahead, next slide. We have the outcome, the scale, the spectrum of clinical outcomes. And this is where, to the left of the screen, kind of the more darker, the black color on the side there, is chronic ankle instability. And again, this is something that is determined more than 12 months out. If they are having these recurrent ankle sprains pretty frequently, then that would be, you know, the more severe level of chronic ankle instability. Moving more to the right, you know, they have frequent episodes of their ankle giving way where they feel like their ankle turns or gives out, but it doesn't really affect their daily life. They're able to kind of get back up and walk again. Moving on to occasional, and then on the far right end of the spectrum is a Coper classification. And these Copers is an individual who, again, is also more than 12 months removed from the initial ankle sprain, but then has not had any recurrent sprains, does not, you know, report any or very, very minimal deficits, symptoms within their self-reported function. They perceive like, I am totally back to normal, I am good to go. That would be considered a Coper, and that's the goal. You know, if someone does sprain their ankle, we want to be able to do all that we can to be able to, where they feel like they have full recovery and they are able to continue on with their daily life and really return back to their back to what they were doing before they got injured. You know, a Coper would not be classified if we move over to the left one section, that is asymptomatic and change activity. So this happens a lot where someone sprains their ankle, they feel like, you know, oh, feel like I'm not able to return back to my previous activity at the fullest potential I can, so I'm just going to give up, or, you know, I can't really dance anymore, so I'm just going to quit dancing. that would not be, but then they, in whatever activity they choose next, they don't really have any other symptoms for chronic ankle instability. That would still not be considered a coper, because they decided to, even though that they're currently asymptomatic, they changed activity. So they technically weren't able to go back to that full recovery. So this is where it's important that trying to determine someone's spectrum of it, because if we're able to determine someone's chronic ankle instability status, then we'll be able to apply a very targeted approach to their treatment. Okay, next slide. Okay, so this is an example created by Dr. Hurdle and Dr. Corbett. This is a patient who is a 35-year-old male construction worker who had a severe ankle sprain 2 years ago and now has a primary complaint of their ankle giving way several times per week. After performing the examination, you can see that there are specific impairments. So there's the orthokinematic restrictions, as you can see from the larger circles. There's altered reflexes, balance deficits, diminished somatosensation, as well as perceived instability. And by measuring all that and you're able to, really determine that someone's, their status falls under the frequent episodes of their ankle giving way. However, if we look on the left and the right sides, we can really examine the personal factors and environmental factors about this patient, which, as you all can imagine and know, as being a clinician, there is never a textbook presentation as well as textbook treatment of someone recovering from an ankle sprain or any injury for that matter. So looking at this, patient's BMI, medical histories, thankfully none other than an ankle sprain, but that's may not always be the case. Poor musculoskeletal flexibility, which probably could be contributing to the orthokinematic restrictions. Moderate self-efficacy, so that's very important to know in regards to compliance. And then looking at the environmental factors, their job is active, so them needing to sit out for a few weeks for recovery of this is not really an option, because if they're not working, then they're not getting paid. So that's something to consider as well. Where they live is also a factor too that we should always be considering. Who their social support or what their social support looks like, as well as their access to healthcare. Okay. So, specifically for patients, we can look at more manual therapy, joint mobilization to address the specific orthokinematic restrictions, a therapeutic exercise program to really improve that somatosensation, reflexive control, postural control, and then ultimately this should help with the perceived instability. Okay, next slide. Okay, so this is a great infographic that was made by the International Ankle Consortium. Their goal is to do a rehabilitation oriented assessment. ROAST is how they create an acronym for it. So this specifically helps clinicians identify any mechanical or sensory motor impairments that are associated with chronic ankle instability, as well as individuals with an acute lateral ankle sprain too. The key components of this clinical diagnostic assessment include, establishing the mechanism of injury, as well as the assessment of the ankle joint bones and ligaments, as well as identifying the muscle deficits too. So hopefully y'all can see this okay. You know, obviously measuring pain, joint swelling, the range of motion, static and dynamic balance. And I'll talk about a lot of this too, but you know, a big thing too is the self-reported ankle joint function. You know, someone will not have any strength deficits, range of motion deficits, or anything like that, but their perception is that their ankle gives way often. So that's something that's also very important too. And I'll get to that more in a little bit. Okay, so next slide. Here we have the clinical outcome measures. And I'll try to move through these a little quicker just for the sake of time. But if you do have any questions associated with it, please don't hesitate to reach out to me. Remember, if you don't measure it, you won't know if there is a deficit or not. If you're doing it just because, then it's not really beneficial for your time or the patient's time as well. So a great way to, and a valid and reliable way to measure dorsiflexion range of motion would be the, go ahead, next one, would be the weight-bearing lunge test. So this was determined that you don't need a fancy inclinometer or 3D motion capture analysis. You could just measure the distance from the wall. So as long as they are performing their max lunge distance from the wall to the big toe, that's in the distance. You know, you can even use your cell phone now to use it as an inclinometer. So that's a great way to measure ankle dorsiflexion range of motion. And then of course the goniometry measurements. What's nice about this, it's a much more dynamic way to measure dorsiflexion range of motion instead of having them, because they're able to provide you have dorsiflexion deficits when you are in contact with the ground often, whereas not so much in an open kinetic chain. Okay, next slide. Obviously, we always want to be measuring strength too. What's also very important is not only measuring strength at the ankle, but also taking a look at the hip abductor strength, or as well as external rotators, because there has been studies done that found that there was a reduced hip strength. Having a reduced hip strength more than doubled the risk of non-contact lateral ankle sprains in male soccer players. So, again, not everyone will have strength deficits maybe at their ankle, but they could at their hip. So measuring their hip strength can be very beneficial. And here is a picture of an isometric handheld dynamometer if you want to be fancy, but manual muscle testing can also be effective too. Or if you have the even fancier isokinetic dynamometer, that may be beneficial too. Okay, next slide. So we'll be talking about two different measures of balance: a static balance, which is this balance error scoring system. This is where patients complete 3 stances: a double stance, a single stance, and a tandem stance in 2 different conditions, a firm surface and a foam surface. So using the RX pads that we all have. They stand with their eyes closed for 20 seconds for each trial. And you are, as a clinician tester, you're counting the number of errors that that the patient experiences. So an error includes lifting their hands off their hips, opening their eyes, taking a step, stumble or falling, moving their hip into 30 degrees abduction, lifting their forefoot or heel, or if they remain out of balance, out of the test position for more than 5 seconds, and that's another error too. If they do all of those in, within 1 second, that just counts as one error. So you don't need to, spend a lot of time critiquing it. This has been shown to be valid and reliable. Great way to, as obviously I'm sure many of you have seen this with concussion return to play or concussion testing too. The next one is dynamic balance. So this is a star extrusion balance test. It has been shown to be reliable as well as valid at detecting those with chronic ankle instability. So it was originally known as the star because it was like an asterisk, the 8 different directions. But, obviously that is a huge time suck. So research was able to only determine that 3 different directions, anterior, posterior lateral, and posterior medial directions, were just as effective at, finding the dynamic balance. So although it may look like a star, really only do 3 directions because it does really help save you time. Important to note too that when they are doing this, make sure that they are standing on their leg, hands on their hips, and they are not transferring their weight or lifting up their heel. And that will help improve the validity and reliability of the test. Okay, also very important to assess during this movement quality too. It's not something that's really measured per se to get a score, but as a clinician, it's important for you to see just to really determine the patient. So if they are lifting their heel a lot to try to get it done, then you could probably determine that there's also some dorsiflexion range of motion deficits associated with that as well. Okay, so here we have the side hop test. Patients go back and forth 10 times. Oh yeah, sorry, next one. There we go. With this side hop test, they go back and forth 10 times. This is a measure of functional performance. So, if they're unable to do this without pain, then, should they really be going out there to play a whole soccer game? That's something that you want to really take note. Or they're not able to get a similar time to their healthy side, then that's something we should consider as well. Okay, next slide. There we go. So now we'll talk about the patient for outcome measures. Again, make sure you click on this link. You'll have access to all of those or the associate articles with it that you can, hopefully incorporate into your clinical practice. We'll be covering perceived instability, kinesiophobia, self-report function, and health-related quality of life. If you are typing this into the search bar and not just clicking the link in the chat, just make note that it is case sensitive, so make sure PRO is capitalized. Okay, so this slide is, thank you, all about measuring perceived ankle instability. So there are 2 different ones. There's actually a couple more than 2 different perceived ankle instabilities, but this is the one that I enjoy using. These 2 different ones. Both of these are also endorsed by the International Ankle Consortium. So perceived instability is, there's the identification of functional ankle instability as well as the Cumberland ankle instability tool. There's just some more information there. So asking questions, this question specifically at the bottom is from the IDFAI, and this is measuring, asking the question of how often does the giving way sensation occur in your ankle. And this is a great way for you to, give a spectrum to the patient for them to really determine. So it never happens, or it happens about once a year, once a month, once a week, once a day. So that score is calculated as, 0 being never, then 1, 2, 3, 4. So that's how that is scored. Both of these studies have been able to distinguish whether what's considered for it to be a COPR. So a 10 or lower on the IDFAI, or a 28 or higher on the CATE. So that's something to keep in mind too if you are trying to determine if someone is a COPR or not. Next slide is about kinesiophobia. So, it's really important to determine that if someone is experiencing a fear of re-injury, then you can really determine if the patient is psychologically ready to return to play or not. And if they are experiencing this, then that's just going to put them at a greater risk of re-injury. So I strongly recommend this for any sort of injury that you come across, is making sure you're assessing their kinesiophobia. The 2 different ones here I have, again, there's likely more, but this is just what I've used, part of my research, as well as from reviewing the literature, is the Tampa scale of kinesiophobia. I don't know if it was really created in Tampa. I'm still trying to figure that out. So if you know, please let me know. But Tampa scale of kinesiophobia, as well as the fear avoidance belief questionnaire. Both of them are great, valid, and reliable. The increase of score, the greater the fear of re-injury. So again, both are great, easy to do, and very valuable information to capture that kinesiophobia that is associated with any injury, not just those with chronic ankle instability. Okay, next slide. Okay, here's a great survey or questionnaire for your patient to complete to measure specifically ankle function. The foot and ankle ability measure was a lot longer, but recent research has come out where it is only 11 questions now. 11. And they've determined it to be, this quick FAM is determined to be valid and reliable. It is also able to differentiate between CAI and COPR, and that cutoff score is 94.79%. It also has a minimal detectable change score of 6.5%. And what this means is that if you are having a patient take it shortly after an injury, and then again right before they return to play, or you want to determine if your treatment is improving their self-reported function, then calculating the scores and then trying to calculate the mean difference. If the mean difference is greater than 6.5%, then you are able to determine that it's outside the error that happens with just any questionnaire. So greater than a change greater of 6.5% means good. That means that there was a significant and meaningful change. Okay, we will go ahead and go to the next slide. Okay, and again, very important, both the kinesiophobia and health-related quality of life questionnaires can really help you determine the level of physical factors that the level of injury that it has on the patient, the physical factors of the patient. This DPA, the Disablement and Physical Activity Scale, was developed by athletic trainers that should be used typically for more physically active populations. this is a great way, because most of the health-related quality of life questionnaires out there, like the SF-12, the PROMIS scales, those are great and wonderful, but typically it's for general population. So it doesn't really take into account the physically active participants associated with it. So take a look at it. As you can see, a great way specifically for the ankle too. A higher score represents a higher level of disablement. Okay, so next we'll move on to the next slide of treatment and rehabilitation, effective treatment. Go ahead, next slide. Okay, so this is the treatment and rehabilitation section of the NATA position statement on ankle sprains. As you can see, kind of our go-to following an ankle sprain has typically been RICE, rest, ice, compression and elevation, but it hasn't really been proven. As you can see, the grade Cs are meaning that there's either not a lot of evidence to support it, or the evidence has been kind of refuting that those claims. So as you can see, the A scores outside of pharmacological treatment are functional rehabilitation as well as balance training. So most of our time and energy should be spent on those 2/3 with joint mobilization. Those 2 or 3 aspects of the rehabilitation. Okay, we'll go to the next slide. Okay, so this is a term, I can't take credit for this. This was created by Drs. Donovan, Rosen, Needle, and Burgle, colleagues in the ankle instability world. They also took a lot of information from Dustin Grooms over in at Ohio University. He is an ACL researcher, so I think the ankle instability world can learn a lot from the ACL research. And they've, especially the researchers I mentioned before, they've done a great job at taking a lot about that and how chronic ankle instability, we are learning, is becoming much more of a central organizational issue over time. So from a treatment perspective, we really need to keep that in mind. And that's probably why a lot of people, or that is why a lot of people, you know, specifically at the ankle, they are good, that all their strength, range of motion, all checks out, but they still feel like their ankle gives way, and they do experience some recurrent issues, likely due to the central organization where the brain and the ankle are not communicating very well. So we should try to shift from our typical rehabilitation of just looking at strength, endurance, agility, power, proprioception into this more multimodal approach coined by Dustin Grooms. And, you know, that's looking at specifically what we'll talk about today is the external focus, visual perturbation, sensory reweighing, dual tasking, and unanticipated reaction. So if we're able to integrate this neurocognitive training into the treatment through this neuroplasticity framework, then it may be proven to be beneficial for those with chronic ankle instability. Next slide. Okay, so here are some effective treatments from the research that I found. This is specifically with manual therapy. Has been shown to decrease pain, self-report function, increase strength and range of motion. You know, this site has done the talocrural joint mobilization and destruction, posterior anterior mob, anterior posterior mob, anterior posterior and posterior anterior of the distal tibiofibular joint, as well as superficial peroneal nerve mobilization. And another factor, what another deficit can be in those with chronic ankle instability is this peroneal nerve nerve conduction velocity deficit. So that's something too we should also be treating not just the typical muscles or ligaments there in that area, all the structures involved in that way. Here is another, go ahead, next slide. The sensory targeted ankle rehabilitation strategies, in case you haven't figured out, they love acronyms in the ankle instability world. So they coined this STARS. So again, typically you wouldn't do these just in isolation, but joint mobilization, plantar massage, and calf stretching have been shown to be, improve specifically dorsiflexion range of motion, single leg balance, and then tricep story stretch was able to really maximize both of those effects. So on the next slide, here are the specific parameters that they did with it, or that they use. So getting plantar massage, 5 minutes, 2 minutes for grade 3 oscillations, and the stretching both with the knee straight and slightly flexed. Okay, next slide. So these next a couple of exercises here is specifically related to the foot core. So this is kind of a novel concept that has been shown to improve balance and perceived instability. And it's something that really kind of enlightened, especially myself, that, if you think about it, any sort of hip or low back injury, our goal is to immediately strengthen the core of, the abdominal core of the body to be able to improve a lot of the deficits. So for us to really have a strong foot core can really bring a lot of or maximize a lot of the effects of anything in the lower extremity. So this is one way to accomplish, and this is known as the short foot exercise. So anytime a patient is doing balance, you want to be able to fire the foot core to improve and maximize the effects of the dynamic balance or single leg balance. So how this is accomplished, and I would like you to try this as well, because it's a lot harder than you may think it would be. So what you do is you pull the head of the first metatarsal toward the calcaneus without curling your toes. So much more difficult than you think. And that can, definitely takes practice, and to progress with this exercise, we can go to the next slide. It's known as this iron bridge. Oh, back one more, there you go. Go ahead, click play. There you go, yeah. Or, this is kind of similar to toe yoga that could be done. I'm sure many of y'all do too. So iron bridge, take 2 textbooks. Typically it's on iron slabs. It's where they get the iron. And lift the great toe, the other toes, do the short foot exercise, and with the heel raise. So much more dynamic and much more difficult than it. And, of course, always going back and incorporating what Dr. Grooms taught us about the multimodal approach. And while they're doing this, have them watch something on their phone, like the VR, or, just watching a roller coaster video on their phone. And that can really improve training the brain to be able to perform these exercises without thinking too much about it. Okay, next slide. Threw this up there just because, very important to incorporate hip strengthening to it as well, especially if they have deficits. Even though it's not specifically at the ankle, we should really be incorporating the entire lower extremity to following an ankle sprain or treating chronic ankle instability. Okay, next slide. These next few videos are related to the balance training protocol. It has been shown to improve clinical and patient-reported outcome measures. So it's all about hop stabilization. And how you progress, you move from, taking their hands off their hips, going, the further distance kind of to the next mark. Those are a great way in these 4 different directions: anterior posterior, medial lateral, anterior lateral, posterior medial, anterior medial, and posterior lateral. And then next slide. Very similar concept, but more with the reach. You hop to stabilize and then reach with the opposite leg, just providing a greater difficulty to be able to be much more dynamic and much more focused in the treatment of these deficits. Okay, we can go to the next slide. And this unanticipated hop stabilization is a great way to get the brain thinking about where they need to end up and how they are going to get there. Always doing it in a random order. This provides the contextual interference to really help train the brain into that neuromuscular re-education. So, the goal is with any of the 3 videos we saw, including this one, the goal is to really be able to do it air-free. If they are able to do it air-free, then that's when we progress. We can progress by decreasing the amount of time that they can spend or that the numbers are coming out at them, or throw in a pad, an Eric's pad or a step, something that increases the level of difficulty. And really important that, you're increasing the level of difficulty when they are able to do it air-free, because that's where strength and that's where gains are gonna occur. Okay, next slide. Okay, this is just some strobe glasses. Obviously these are a little bit more expensive, so don't worry if you don't have the capability of it, but it's to really simulate a playing environment using the visual perturbation and sensory reweighing. The stroboscopic training incorporates the dual tasking that uses the environmental interaction while adding that visual obstruction. Very similar to if you stand with your eyes closed, it's a lot more harder than standing with your eyes open. So we'll just go ahead and go to the next slide. So here's just video of me trying to do it. I don't even think I had the goggles on at that point. It was just difficult for me to begin with. But it does make it a little bit more difficult to where we're able to really upgrade this typical single leg balance ball toss by simulating this more of a environment. Okay, next slide. So, this is another concept of dual tasking to where I'm only being told to catch the yellow balls. So that's making me think, as well as the classes are going. Again, the more we can throw in more factors during these typical single leg balances, the better outcomes will be. Go ahead, next slide. Oh, I have the sound on. Yep, with this next slide, just a slapping hands with a partner as a clinician to make it more difficult. The clinician can, change the height of the slap, so the patient's going to need to think that way. It really does simulate that environment, because when you're playing sports or doing any sort of physical activity, you're not really constantly paying attention to your ankle to prevent injury. So the more we can do that in a controlled environment, the better outcomes will be. Okay, next slides. Okay, these next couple slides are related to gait training. It's another way to, using the lasers, as you can see here, is another way for external visual feedback. And Luke Donovan and his team at UNC Charlotte has done a great job related to gait training. I'm sure we'll find much more research coming out of there specific to it. It has been currently shown to improve center pressures. So the laser attached to the shoe can really provide that visual feedback for the patient with the goal of, okay, keep the laser aligned with the wall, and that should help them be like, oh, this is how I should be walking. Because shockingly, those with chronic ankle instability, there has been research done that where they demonstrate gait training deficits. So this is one way to really improve those deficits. Similar here for the next slide. This is just a way to, a contraption created for gait training that perturbs the limb medially. So it causes the patient to abduct their hip to really correct the gait patterns. And it has been shown to improve self-reported function. Okay, next slide. You can turn off the sound for this. But try to hit play. Oh, bummer. That's okay. So this is something I haven't seen any research on it, but it is where putting the patient into a lunge position like this and having them do a calf raise, just really demonstrates the importance of incorporating multiple compound movements into the treatment like this. Because if ankle mobility is one of the deficits, then this can certainly help improve that, as well as provide much more opportunity for your hamstrings, adductor, soleus to really work synergistically with each other. The more they can work together, the better chance they have at preventing that ankle sprain. Okay, next slide. Okay, so this next slide is related. This was presented at International Ankle Symposium by Dr. Smith over in Australia. And she coined this term, ankle sprains need to pass before they return to sport. And what that means is that they should be able to perform the tasks, the sport-specific activity error-free or pain-free, and of course error-free, to the best of their ability. Address any ankle impairments as well as ankle perception. That's where the fear avoidance belief questionnaire (SK) comes into play, the kinesiophobia questionnaires, as well as making sure that they are able to perform the sport-specific drills accurately and in a time or performance up to their standards, as well as addressing the sensory motor control through dynamic balance and proprioception. So if they're able to do all that safely and accurately error-free, then they are able to return to sport safely. So just to summarize, sorry for going 5 minutes over, but I just wanted to reiterate again, it's not just an ankle sprain anymore. More and more research is coming out where it is a significant healthcare burden. We want to make sure that we're using valid and reliable clinical and patient-reported outcome measures needed to progress or track progress, as well as determine their return to play. Thank you. Making sure that we are taking a targeted approach to treat the very complex chronic ankle instability, as hopefully you learned from this presentation, and really make sure you're treating the ankle sprain to pass, to return to sport. So that is all I have. And of course, if you're having trouble with motivation, don't forget that treats can always be helpful and always work. So I can take any questions, or feel free to reach out to me anytime. My email address is on this slide, and I'll be happy to answer them. Thank you for having the slides ready.
Not a problem, not a problem. I'm glad that was able to work out. I'm going to give a minute or two here for some questions to pop up. All right, so Mary is asking, would you always recommend balanced training protocol on carpet? And then if carpet is unavailable, what surfaces would you recommend to perform these exercises?
Either or, carpet or floor is fine. Obviously you want to make sure that it's a safe environment. So if the floor is a little bit more slippery, then sure that they're safe. You can definitely do it in shoes if that provides a little bit of a safer environment. Typically barefoot also works too, because we're able to fire all the smaller intrinsic muscles of the foot. But if we just had carpet in our lab, so that's why we had carpet there. So it was very, it wasn't like plush carpet or anything like that. So very flat surface. So just any flat surface will be completely fine.
All right, great. Well, if you have any other questions, and there, Jorge or George is asking, is there any research comparing the benefits on arch raises sitting versus standing?
I do not know that specifically. I think the research that had been done related to that short foot exercise was they were done standing. So I would recommend standing, because that's where ankle sprains are going to typically occur in a more dynamic setting. So having them do standing. However, if they have difficulty doing standing initially, then definitely starting them in a seated position to really just focus on the form, and then moving from then progressing to standing as well.
Christine asks, what are your thoughts on an athlete wearing an ankle brace daily versus daily ankle taping?
Oh, that's a huge debate, and definitely can talk much more, another hour or two about that. But yeah, no, ankle sprain or ankle bracing taping is a huge topic. It really all depends. There's not a lot of strong evidence out there stating that ankle taping reduces the risk of re-injury of the ankle. The bracing has been shown to decrease the risk of ankle sprains compared to taping. So it really all depends, that ankle bracing taping approach. What also has been done is that there's a much greater impact of taping or bracing in those with a history of ankle sprains. So if someone doesn't have a history of an ankle sprain at that point, then they are at an equal risk, maybe slightly lower, of spraining their ankle. And what's important to note too is that with bracing or an ankle taping, the force that goes into an ankle sprain will exceed that of bracing or taping. So we want to make sure that, so typically an ankle sprain will happen, regardless if they're taped or not, but it's the more of the deficits associated with chronic ankle instability, like giving way, where bracing and taping would be very beneficial. But if it's initial ankle sprain, or or they're coming back from injury, definitely taping, bracing, whatever you can do to protect the joint as much as you can. But if it's someone who has never sprained their ankle before, not even at a high risk, then taping and bracing has shown to be beneficial. But again, that's a whole nother topic that can be further explored. That's just coming off of my memory without much recent literature review.
Nadine asks, what's the evidence of utilizing a walking boot with early ankle sprains?
I think with the walking boot, definitely valuable, because the goal too is to protect the joint early on, and that's a great way to do it. I would just also recommend too taking them out of the boot as often as possible to do the little exercises that they can that is appropriate for their progression. So if they are early on, I think a walking boot would be completely beneficial. It's personally probably better if they're able to walk in it pain-free, or with a little pain, better than crutches, because when you're introducing crutches into it, then that's just immobilizing their entire leg, including their hip, which will then decrease the hip strength, decrease the knee strength. So again, if a walking boot works better for them, then all for that. But the goal is to try to get them out of it as quickly as possible, to avoid any muscle atrophy that happens with immobilization in general.
Mm-hmm. Colleen asks if they discussed at the symposium, or if you've seen any correlation between chronic ankle instability and osteochondral lesions of the talus.
I can't recall off the top of my head at this point. Possibly. I think I'm sorry, they have, because this is what it comes along with the ankle osteoarthritis. So typically also what happens too, following an ankle sprain, is that depending on the ligaments and how much force was done following an ankle sprain, it can definitely put the talus at risk from that kind of bone bruising that happens following an injury. So I don't have the specific number or the statistics with that, but it's something that we should always be considering, specifically with our differential diagnoses of more severe ankle sprains, especially the recurrent sprains of individuals with chronic ankle, the severe end of chronic ankle instability, where they don't really have the ligaments to support. So, I know when I sprain my ankle now, it's like bone on bone. So that's something that should always be considered in putting the talar dome at risk of injury.
All right, so that is all the questions I have. Thank you for your time, and thank you to everyone who joined us tonight. And we look forward to seeing you again soon.
Thank you.